Okay, let's unpack this. Imagine needing a critical lifeline, um, a really reliable connection to get treatments that keep you going, maybe dialysis, chemo, special nutrition, not just once, but again and again, sometimes, well, for years. How do medical teams actually create that kind of dependable path into your body's network of blood vessels?
That's exactly what we're digging into today. It's all about vascular access. Put simply, it's the methods used to set up these reliable long-term ways into the venous system.
Into the veins, right, where blood flows back to the heart.
Precise.
Yeah, it's clearly much more involved than like just finding a vein for a temporary VB. It's about engineering something durable.
That's a good way to put it, engineered. And the sources we looked at, they really lay out the detailed techniques, the specific spots doctors pick, and the real-world challenges in getting these access points set up, and just as importantly, keeping them work.
Right. So our mission here is to pull out the most crucial insights from this material for you.
And it's a big topic, definitely not niche. The information we reviewed really highlights the scale. Think about chronic kidney disease in the U.S. alone.
Yeah.
It affects up to 26 million people. That's, 13% of the population? And it hits older folks over 65 even harder.
Wow, 26 million? That's huge. And the text specifically mentions over 480,000 people with kidney failure needing that reliable access just for hemodialysis.
Just for dialysis, yeah. And then you add in all the other reasons people need these chemo, nutrition, other long-term meds. The estimate is something like 2.75 million vascular access devices placed every single year.
Millions. Okay, so clearly significant. Why should you, listening now, care about this?
Well, because understanding these sort of hidden lifelines reveals some incredible medical ingenuity, some really clever techniques. But maybe more than that, it shows the huge ongoing challenges patients face managing chronic conditions day in, day out.
It definitely gives you a new appreciation for the complexity. So the info we have points to, two main ways they achieve this long-term access?
That's right, two main paths. One is surgically creating a connection between an artery and a vein that's called an arteriovenous fistula, or AV fistula for short.
Okay, surgery.
And the other path involves placing different kinds of catheters or port devices directly into veins, usually the bigger central ones.
Got it. Let's maybe tackle the surgical one first, the AV fistula. This often gets called the gold standard, doesn't it? Especially for long-term dialysis patients.
It does, yes. For people with end-stage renal disease who need hemodialysis ongoing, creating what's called an autogenous AV fistula, meaning using the patient's own vessels, is generally the top choice.
Autogenous, so using their own veins and arteries.
Exactly. And the idea behind it is, well, it's simple but really clever. You surgically connect an artery,
which has that high pressure flow going away from the heart.
Right. You connect that directly to a nearby vein, which normally handles lower pressure blood returning to the heart.
And what does that connection do? What's the result?
Well, that blast of higher pressure arterial blood flowing into the vein forces the vein to change. It adapts. It starts to dilate, get bigger, and its wall actually thickens up.
Oh, okay.
This whole process, they call it maturation, and it doesn't happen overnight. It usually takes weeks, maybe even a few months.
It's a month, okay.
But once that vein has matured, it's much larger and tougher than before. It becomes suitable for the repeated needle insertions needed for dialysis session after session. You're essentially turning a regular vein into a sort of vascular superhighway.
Superhighway, I like that. And where do they typically create these? Location must be pretty important.
Oh, absolutely crucial. I mean, technically you could do it anywhere a suitable artery and vein are close, but the upper limb, the arm, is overwhelmingly the most common spot.
Makes sense.
Yeah, factors like patient comfort, how easily the dialysis staff can access it, minimizing the impact on the person's daily activities, all that plays in.
And within the arm, are there preferred vessels?
There are. The goal is usually to use arteries like the radial artery that's on the thumb side of your wrist, the ulnar artery on the pinky side, or the brachial artery up near the elbow. And for the vein side, they often look at the cephalic vein, that's the one you can sometimes see running up the outside of your forearm, or the basilic vein, which is usually a bit deeper on the inside of the arm.
And I noticed the text mentioned starting low down on the arm, near the wrist, if possible. Why that specific strategy?
Yeah, that's a key principle, start distal. Creating the fistula, using the vessels furthest down the arm first, like that radial cephalic one at the wrist. It basically saves the vessels higher up, more proximal, for later use. If that first fistula eventually fails, or there's a problem, you still have options higher up the arm to create a new one.
Planning ahead. Makes sense.
Exactly. Now, if the patient's own veins aren't quite suitable, The material does mention using synthetic graft material, like a tube, to bridge the artery and vein.
Ah, okay. A graft.
But generally, the fistula is made purely from the patient's own vessels. The autogenous ones tend to last longer and have fewer problems down the line.
Okay, so the surgery happens, the fistula is created. What are the immediate concerns right after?
Post-op care is critical. Right away, a big worry is acute thrombosis, basically, the fistula clotting off.
Oh, right.
That can sometimes happen due to technical issues during the surgery itself, so you need to check constantly for what's called the palpable thrill. That's a vibration you can actually feel over the fistula site.
Like a buzzing.
Kind of, yeah. And the audible bruit, that's a whooshing sound you can hear with a stethoscope. Both of those signs mean blood is flowing well. If that thrill feels weak or disappears, that's an urgent warning sign.
Got it. Thrill and bruit.
And managing blood pressure, fluid balance, also really vital right after surgery.
An infection, I assume, is always on the radar after any surgery.
Always. Checking the incision site for redness, warmth, extra swelling, any drainage. Watching for fever, that's standard. Bleeding or hemorrhage is another potential early issue. So looking for hematomas, collections of blood under the skin, or just excessive bleeding.
Okay.
Swelling or edema is pretty normal at first because of the surgery and the changed blood flow. Keeping the arm elevated helps. But if the swelling is really severe or doesn't go down, it could point to a deeper issue like a venous thrombosis, a clot in the vein itself.
Okay, that covers the immediate aftermath. What about later on, once the fistula is hopefully mature and being used? Are there different problems then?
There can be, yes. Long-term late thrombosis is still a risk. This often happens because the repeated needle sticks for dialysis over months and years can cause scarring and narrowing stenosis of the vein where the blood flows out.
Ah, wear and tear, essentially.
Sort of, yeah. So checking that thrill and bruit daily, that remains absolutely vital, both for the patient to do themselves and for the clinical team.
And the sources brought up some potentially tricky issues related to blood flow changes, hemodynamic complications.
Right. This is where creating that high-flow connection can sometimes cause knock-on effects in the circulation. Congestive heart failure is one possibility.
Really? How does that happen?
Because the fistula creates this shortcut, this low-resistance path, a lot more blood returns to the heart than usual. The heart has to work harder to pump that extra volume. Over time, that can strain it.
Wow.
Then there's something called steal syndrome. This happens if the fistula steals too much blood flow away from the hand, the area below the fistula site.
Steals blood from the hand.
Yeah, it diverts it into the fistula instead. So the hand might feel painful, cold, numb, maybe weak, especially when trying to use it.
That sounds quite serious.
It can be. Another issue from repeated needle sticks is a pseudoaneurysm. This isn't like a true weakening of the vessel wall itself, but more like a leak that creates a little pocket of blood outside the vessel, forming a pulsating bulge under the skin. And sometimes, as the vein deals with that high flow long term, you can get a true aneurysm where the actual wall weakens and balloons out. Those might need surgical repair. Chronic swelling, skin changes around the fistula, even nerve issues like carpal tunnel syndrome due to pressure, those are also listed as potential long-term problems.
It really drives home that creating the fistula is just the beginning. Managing it successfully for, potentially years is a huge ongoing effort.
Absolutely. Which is why patient education is so heavily emphasized in the material we reviewed.
Makes sense. The patient has to be involved.
Totally. They become active partners in this. They need to be taught how to check their own thrill every day and, crucially, report any changes immediately. They have to know the signs of infection.
Right.
And a really key point, avoid anything constrictive on that fistula arm. No blood pressure cuffs on that arm, ever. No tight sleeves, no watches, don't carry heavy bags on that shoulder. Anything that could squeeze the fistula and reduce blood flow is a no-no.
That's critical information.
Definitely. And simple things like encouraging hand grip exercises after surgery can actually help the fistula mature faster. It really becomes part of their daily life, their self-care.
Okay, that gives us a really good picture of the AV fistula approach. What about the other main method you mentioned, the percutaneous catheter access? Going through the skin?
Right. So this involves inserting a catheter directly through the skin and into a vein. It's often aimed at a bigger, more central vein, closer to the heart. A common way they do this uses the Seldinger technique.
Seldinger?
Yeah, it's a standard method. Basically, you use a needle to get into the vein, thread a guide wire through the needle, remove the needle, and then slide the catheter over the guide wire into place. It was developed for all sorts of things, quick fluid delivery in emergencies, but also for longer-term access for, say, nutrition, antibiotics, or chemotherapy.
And which veins do they usually target for these central catheters?
Common spots are the subclavian vein, which runs under your collarbone, and the internal jugular vein in the side of your neck. The femoral vein down in the groin or upper leg can be used too, but it's often less preferred for long-term use.
Why is that?
Generally, a higher risk of infection compared to the neck or chest sites.
Gotcha. And the sources talked about different types of these catheters, didn't they?
They did. For longer-term needs, the focus is often on central venous tunneled catheters or implanted ports. These are designed specifically to stay in for a long time.
Tunneled? What does that mean?
It means part of the catheter actually runs under the skin for a short distance before it enters the vein. They're usually made of flexible stuff like silicone. And a key feature is this little cuff attached to the catheter, positioned under the skin.
A cuff?
Yeah, it helps anchor the catheter, and over time, your body tissue actually grows into this cuff. That creates a kind of barrier that helps seal off the tract and reduce the risk of bacteria traveling down the catheter from the skin surface.
Ah, clever. Like a biological seal.
Exactly. Some newer ones even have antimicrobial stuff built into the cuff material. And these catheters can have multiple lumens, separate channels inside the single tube, so you can run different IV fluids or draw blood at the same time without them mixing.
Okay, and the ports, how are they different?
A port is similar, but it's entirely implanted under the skin. There's a small reservoir with a silicone top connected to the catheter that goes into the vein. There's nothing visible outside the body. To use it, you have to access it by sticking a special needle through the skin into that silicone top.
So, totally hidden.
Yeah.
What are the pros and cons of these tunneled catheters and ports?
Well, the advantages listed include generally lower infection rates compared to, say, temporary IVs or even non-tunneled central lines. The port offers a very discreet cosmetic advantage since it's all hidden, and having multiple lumens is handy for complex treatments. The downsides, well, for the tunneled catheter that exits the skin, you need meticulous daily dressing changes at that exit site. For both types, you need regular flushing, usually with heparin and anticoagulant to stop the line from clotting off when it's not in use.
Heparin.
And there's the ongoing cost and the need for supplies for maintenance.
Then there are PICC lines, too. Peripherally inserted central catheters.
Yes, PICCs fall under this category, too. They are central catheters because the tip ends up in a large central vein near the heart. But they're inserted differently. They go into a smaller peripheral vein, usually in the upper arm, maybe near the elbow or higher up, and then threaded upwards into the central circulation.
Okay, inserted in the arm, ends near the heart. What's the advantage there?
Often easier placement. Sometimes it can be done right at the bedside or in an outpatient clinic. Doesn't necessarily require a full surgical procedure suite. And removing them is usually pretty straightforward, too.
But they have downsides as well, I imagine.
They do. They still need careful daily care, sterile dressing changes at the insertion site, usually with a dressing that seals the area completely in occlusive dressing. And the infection risk might be a bit higher than with a fully implanted port, although often lower than temporary non-tunneled lines.
And then there are catheters specifically for hemodialysis.
Yes, dedicated hemodialysis catheters. You can have non-tunneled ones for very short-term urgent dialysis access. Or tunneled dialysis catheters, TDCs, which are for longer use, but often they're still seen as a bridge.
A bridge?
Yeah, like a temporary measure while waiting for an AV fistula to mature, or if a fistula isn't possible. The sources are really clear. These dialysis catheters have super strict rules. They should only be accessed by trained dialysis staff and only used for dialysis treatments, nothing else.
Right. Keep them pristine for that one job.
Exactly. Because while they're essential for getting dialysis started quickly, they're generally considered less ideal for permanent, lifelong access compared to a well-functioning AV fistula. They tend to have a higher rate of complications over the very long term.
Speaking of complications with these catheters, what are the main worries? What do doctors and patients need to watch for?
With central venous catheters, there are risks right from the start, during the insertion procedure itself, especially when putting them into veins in the chest or neck near the lungs and heart.
Like what?
You could potentially cause a pneumothorax, that's a collapsed lung, if the needle accidentally nicks the lung lining, or a hemothorax where blood collects in the chest cavity. An air embolism is a scary one, an air bubble getting into the bloodstream. And very rarely, direct damage to the heart or major blood vessels, like cardiac perforation.
Okay, those sound like immediate procedural risks.
Yeah.
What about later on?
Longer term, the big concerns are mainly infection and clotting. Infection is a major one, particularly catheter-related bacteremia or sepsis, a serious bloodstream infection. It often starts from bacteria on the skin migrating down the catheter tract.
Especially risky for some patients.
Definitely. Patients with weakened immune systems are at higher risk. Then there's the risk of the catheter lumen, the channel inside, just clotting off so you can't infuse fluids or draw blood. That's catheter occlusion.
Okay.
And thrombosis, this means a blood clot forming in the vein where the catheter is sitting. That can block blood flow, cause swelling, and potentially lead to a pulmonary embolism if a piece of that clot breaks off and travels to the lungs. That's very dangerous.
Pulmonary embolism, right.
And over time, the vein itself can narrow around the catheter, which is called vein stenosis. That can cause problems with blood flow in the limb later on.
So it sounds like whether you have a surgical fistula or one of these catheters, really vigilant care and monitoring are just absolutely essential, both from the medical team and the patient.
Couldn't be more true. Nursing care focuses heavily on meticulous, sterile technique. Every time the dressing is changed, every time the line is accessed, it has to be done correctly to prevent infection.
Right.
Regularly checking the insertion site, asking the patient about any symptoms, fever, chills, pain, redness. That's crucial for catching infections early. Preventing clots is also key, using the right flushing protocols with saline or heparin, and noticing immediately if there's any resistance when trying to flush or draw blood.
And watching for those clots in the vein.
Yes, assessing the arm or neck area around the catheter site for any new swelling, pain, or skin discoloration that might suggest a venous occlusion, that dangerous clot.
And you touched on this earlier, but there's the whole human side, too, the psychological impact of having a device like this, especially one that might be visible.
Yeah, the information we looked at definitely highlights addressing body image concerns. It's part of comprehensive care. Teaching patients practical things like how clothing choices might help conceal an external catheter if they want, or specific advice on showering and hygiene to protect the site.
Helping them adapt.
Exactly. Helping patients integrate this necessary device into their lives as smoothly as possible, trying to minimize the psychological burden it can sometimes carry.
So this deep dive, drawing from all these detailed sources, it really boils down to these two fundamental strategies for getting that long-term vascular access: the surgical AV fistula route and the percutaneous route using various catheter supports.
That really is the core takeaway. Both methods serve that absolutely vital function, providing a reliable gateway into the circulation when someone needs repeated, long-term access for life-sustaining treatments, dialysis, chemo, long-term IV nutrition, whatever it might be.
But as we've discussed, they get there through very different means, right? Different procedures, different spots on the body, and each has its own specific set of potential complications and ongoing care demands.
Precisely. And the decision between them isn't simple. It's a complex medical judgment call based on exactly why the access is needed, for how long, the patient's overall health, the condition of their own blood vessels, lots of factors.
Yeah. It seems like while the AV fistula is often preserved for that long-haul durability in dialysis, it needs that maturation time and has its own surgical and flow-related risks.
Right, whereas catheters offer that immediate usability, which can be absolutely critical in urgent situations.
All right.
But they might carry different risks, or perhaps higher risks over the very long term, especially concerning infection and certain types of clots, when you compare them head-to-head with a mature, well-functioning fistula.
And all these details, from the anatomy and the surgical techniques to the day-to-day care, the potential problems, the trade-offs, that this all comes straight from the in-depth information we've been digging through. It really underscores the specialized knowledge and just constant watchfulness needed, not just to create these access points, but to keep them working safely over time.
It really does, and it leaves you with something quite profound to think about, doesn't it? Consider that incredible balance patients have to navigate every single day, relying on these engineered connections inside them for life itself, while also needing constant daily vigilance to maintain them and ward off potentially serious complications. It's a remarkable ongoing interplay between medical technology, human resilience, and dedicated care.